So, dear friends, I welcome you to my channel. I'm Dr. Panayotis Georgiou and I'm an ENT consultant trained in Germany, now placed in Cyprus. I'm here working as an ENT consultant. What I would like to do in this channel is to explain ENT topics in an easy to understand format for you to be able to revise your topic of liking. Either you are an ENT specialist, ENT specializing doctor, or a student of medicine, and you need a deeper understanding on an ENT aspect, on an ENT topic, then I want this channel to be your go-to channel in order to have a very good summary of all the topics that you need. Now let's jump right in. We're not going to be wasting any time in this channel, and I will be explaining you directly the topic. Today's topic is neck malformations, and I would like now to jump to my iPad screen in order to show you the congenital neck malformations. The most common one, and the number one most commonest, will be a thyroglossal duct cyst, and then the second most common will be a brachial cleft cyst. For the thyroglossal duct cyst, we already made a video. Go and watch that if you like. Now we're going to be concentrating on the brachial cleft cysts, as you can see, of course, in this picture. So, first and foremost, you will need to understand our embryology in order to really comprehend the formation of the brachial cleft cyst. And we start at the pharyngeal apparatus. As you can see here, the pharyngeal apparatus consists of arches, grooves or clefts, and then pouches. In total, we have 5 pouches, 4 grooves, and 5 mesodermal arches. The grooves and clefts are concised from an ectodermal tissue, while the pouches are from an endodermal epithelium. Of course, the arches are mesodermal tissue. So an easy way to remember this will be an ectodermal tissue makes clefts, while an endodermal tissue makes pouches. That's something for you to remember. Now, so as I said before, we have mesoderm, ectoderm, endoderm, ectoderm. In the ectoderm here you find clefts. In the endoderm you find the opposite of clefts, which is pouches. And then for the mesoderm you have arches. 5, 5, 4. Now the formation, as you already know, or you may already know, the definition of a brachial cleft cyst is the inhibition, malformation, and incomplete regression of the cervical sinus of His. We can see here the cervical sinus of His. But what does this actually mean? I will bring your attention here in this drawing. We have also we have the endoderm and the ectoderm, and then we have the second pharyngeal arch, and then the fourth pharyngeal arch. During the 3rd to 4th embryonal week and up until to the 6th embryonal week, we can see an overgrowth of the 4th and 2nd pouch. So this overgrowth here, yes, will come to form the so-called cervical sinus of His. If I can bring your attention here, then we will see here the ectoderm and here the endoderm. Yeah? And so here, this overgrowth of the 2nd arch and the overgrowth of the 4th arch will form a small opening in the pharyngeal apparatus. This is called the cervical sinus of His. In further development and up to the 6th week, this sinus will be closed. This sinus will be closed, and this gap here will be filled with mesodermal tissue, but not if you have a brachial cleft cyst. It's the incomplete regression of the cervical sinus, and now you know exactly what that means. Either the cervical cyst will be connected to the skin And in this case, we will have a fistula formation. Either it will be closed from the skin and then we'll have a cyst formation. There is a very common theory of why does the cervical sinus of his why doesn't it close, and this is called the LIAT theory. The only thing that you need to know here is LIAT is an acronym for local interepithelial adhesion, and local intraepithelial adhesion does not work in this region. That's why the cells don't come together and they don't close this sinus. Further, speaking about the symptoms of these brachial cleft cysts, most commonly we will see them in children right after birth, but they can also occur later in life. And we can divide the symptoms between fistulas and cysts. If you have a fistula, then you will see an opening on the neck of the patient. Where will this opening occur? It will be at the anterior border of the sternocleidomastoid muscle. This anterior border of the sternocleidomastoid muscle, it will be either in the level 2, level 3, or level 4 of the anterior border. Most commonly though, will be in the level 2. This is the most common location to see a second brachial cyst formation in the neck. Now, sometimes after an upper respiratory tract infection, you can see some milky or some purulent secretions from this cyst. If this is repeating, then we're going to see a granulation tissue formation, as you can see here in the picture. This is caused due to repeated infections, as we said before. Now, a very good clinical point here is that if you see a bilateral formation of a brachial cleft cyst, you need to exclude the so-called brachio-otorenal syndrome, seen here in this case. Now, a very good point here to show and tell will be the connection between a second brachial cleft cyst and the ipsilateral tonsil. And what we see is sometimes, very rarely, but sometimes you can see this fistula that's going and connecting either to the inferior pole of the ipsilateral tonsil or to the, very rarely, to the posterior pharyngeal wall in this area. Now, two anatomical points that are really important when you're operating these patients will be the association with the hypoglossal nerve. So this fistle goes underneath the hypoglossal nerve, yes, and you will find this here in most commonly deep in the neck. Now, of course, a very typical association of these fistulas will be also the bifurcation of the common carotid artery. You will see it running over the common carotid artery. So a fistal formation of a brachial cleft cyst runs over the bifurcation of the carotids and then under the hypoglossal nerve. Just keep that in mind. Now, if we're talking about cysts, as you can see here in the picture, the cysts are also forming at the anterior border of the sternocleidomastoid muscle. They usually have an oval shape, and the patients are coming to us, they're mid-20s, late 30s, yes, these ages, and they have a rash swelling in this area, especially after an upper respiratory tract infection. Now, on palpating this cyst, it will be elastic and bulging at the neck. A good sign to differentiate between thyroglossal cleft cysts will be to have the patient swallow. If the cyst is moving, then it's most likely not a brachial cleft cyst, rather a thyroglossal cleft cyst. Now, in some cases, these cysts are infected. In this scenario, then you will have a redness of the skin overlying the cyst. You have swollen cysts that are painful to manipulate, and sometimes you can see there an abscess formation. Now, if the cyst is not infected, you will have a non-painful bulging elastic cyst on the neck. If we're talking about a huge cyst, yes, more than 6 centimeters in diameter, then you have the 3 Ds. What are the 3 Ds? Dysphagy, dysphonia, and dyspnoea. Now here I have some pictures for you how you can locate this cyst. Now, of course, here if it's so massive, it's hard not to miss. And then here you can see in this image, and I've marked them for you. The cyst comes on the lateral side of the neck and pushes the carotis and the carotid sheath with the jugular artery and the vagus nerve medially. Yeah. Here you can see the direction of the carotis. Here is the carotis on the other side, and then here you can also see, if I remove my markings here, you can also see this effect of closing of the jugular artery and the swelling of the proximal part of the jugular artery, of the jugular vein, sorry. Now, moving forward to diagnosis. Of course, it's very, very important to do a thorough ENT evaluation on these patients. Yeah, and an ear examination. I will talk later about that. But in the ENT examination, you should include ears, you should include nose, you should include mouth, you should include an endoscopy from the patient. You should also include an anamnesis. And in the anamnesis, you will need to ask the patients what they eat, if the swelling of the cyst have any relation with what they have eaten, or if they had recently an upper respiratory tract infection. Now, the next step is to do an ultrasound. In this ultrasound, you will see a cyst that has good borders and it's anechoic. Also here, you will see the medial displacement of the common carotid artery and the bifurcation of the carotis. Now, it's usually recommended to do an ultrasound. It's very, very much recommended to do an ultrasound and an MRI, especially with contrast agents. Yeah. Now, a CT examination, if your most likely diagnosis will be a brachial cleft cyst, you don't actually need it. Now, the question comes often from the patients if they actually need to remove it. Yeah. Now, I will always recommend the patients to remove brachial cleft cysts for one single reason. They can either be metastasis from head and neck tumors, or in less than 1% of the cases of a tumor occurring inside a branchiogenic cleft cyst will be a true squamous cell carcinoma. They're also called branchiogenic tumor. If it's solid, if it's rapid growing, if it's firm on touch, and if you see it in an adult more than 40 years old, these are all red flags in order for you to act quickly. Now, what about the treatment? How do we treat these kind of cysts? First of all, if they are infected, you need to admit the patient, you need to administer IV antibiotics, some pain medication, but the typical therapy for these patients will be an operation. The incision should be placed above the cyst in a wrinkle line on the neck, and be generous with your incision. You will have at the end of the operation to recognize, you will need at the end of the operation to recognize the bifurcation of the carotis, maybe the hypoglossal nerve, maybe the common carotid artery. So be generous with your incision and just suture an intradermal suture at the end in order for you to leave minimal scarring. Now, if the most important step of the operation is before the operation, when the patient signs the consent form, you need to explain the patients that there is a possibility that you will need to remove the tonsil on the ipsilateral side as well, for the reasons that we've talked before. Now, By making the incision, as you can see here, you need to be careful not to damage the jugular artery, and then you prepare the cyst all around. If the cyst is so massive that you cannot control it, or you cannot really have a good visual field, you can drain it with a needle, and then you can either clamp the opening of the drainage with an artery in order to minimize spillage, or you can suture it like you're suturing at the appendix removal. Yeah. If you reach the common carotid artery bifurcation, then you will really need to consider removing also the tonsil on the side. If it's a big cyst, as we said before, drain it, and let's go further. Now, if you have a fistula in the area, yeah, you will need to follow this fistula. The common locations that you can see it is either on the level 4, level 3, or level 2 of the neck, and in this case you have two options. Either you will do a very big incision along the anterior border of the sternocleidomastoid muscle, or you will do along the border of the anterior border of the sternocleidomastoid muscle, you will do small incisions, as we can see here in the picture, in order to follow the fistula and feed it through as a tunnel. For the inexperienced surgeons, it will be better to do a larger incision. For the experienced surgeon, the small multiple incisions will be better for the aesthetically pleasing result at the end, especially in children. Now, if you can see the fistula, yeah, you can use methylene blue in order to mark its territory, and use a probe in order to see if it's coming out through the mouth and if you will need to remove the tonsil. Always take care during the operation of the big vessels in the area, as we've talked before, and the hypoglossal nerve. As I told you before, the fistula runs over the hypoglossal nerve, as we see here in the picture, yeah, and then in front of the bifurcation of the carotids. So that will be all for the brachial cleft cysts. A review now. In general, there are 4 types of brachial cleft cysts. We only talked about the second one, which is the most common. The first pharyngeal arch cleft cyst will be seen in another video, and that's why I told you that you always need to examine also the external auditory meatus in order to exclude a simultaneous pharyngeal cleft, pharyngeal arch, fistula of the first pharyngeal arch, and then the second and third pharyngeal arches. Fistulas will be extremely rare. Either they will appear behind the common carotid artery, or they will appear at the apex of the piriform sinus. I want to leave you with a quote of the day, and then the quote of the day is do the thing. You're doing the thing by watching the video. Keep reviewing your ENT topics. Keep improving on your ENT examinations, and keep coming back to watch my videos. Thank you very much, and I will see you in the next video.